And we're on. Hello, everyone. Hello, Anish.
Hi, Michelle. How are you?
Fine. How are you?
Good. Another rainy day.
Is that right?
Yeah, it's been I don't know, 7 or 8 or 10 days of rain straight. It's amazing. Has it been? What's the weather like over
Blue
in
skies.
beautiful?
Blue skies.
Oh, blue skies.
It's
Like
actually a little chilly today.
yeah.
The typical San Francisco summer type weather. Um, Good. Shall we get started?
Yeah.
So we have a paper here. I think you'll summarize it. But before you do, I want to read the tweet that sort of caught my attention by someone who's I think a healthcare reporter, or I'm not exactly sure. I think so. I think he's sort of a healthcare journalist, and he retweeted this, or he tweeted this in regards to the paper we're going to discuss today, and he said, "This is a great story that proves you don't even need an effective drug to make billions. You just need an effective marketing campaign." Okay, so we're gonna see if that's the case. But I think it's a good summary of the editorial, or at least the gist of the editorial. I mean, that's what
Yeah.
the editorial was trying to convey: that you don't need an effective drug, you just need a marketing campaign, and boom, you make billions of dollars.
Right.
Okay,
So the editorial is in JAMA. It's by
JAMA Internal Medicine,
JAMA Internal Medicine.
the
Yes.
journal of less is more. Yeah.
Yes. So Lisa, so Lisa Schwartz from the Dartmouth Institute for Health Policy, and Stephen Voloshin, the Center for Medicine and Media, also the Dartmouth Institute for Health Policy. So that automatically tells me that they're probably not seeing that many patients, but well, maybe I'm
Right.
wrong.
Well, I don't know. But it tells me that they tend to have an angle on things.
Yes. There's always an angle. Well, we have an angle too. But anyhow, so the title of the article is the editorial is a clear-eyed view of restasis and chronic dry eye disease. And they start out by talking about the fact that there's a legal maneuver that the Allergan, the company that makes Restasis, has done in order to try to extend their patent by licensing their patent to some tribe and the tribe is going to license it back to them. All of it to some legal loophole that they're trying to exploit to kind of extend the patent protection. But the drug itself is a cyclosporin type of gel, which I guess was one of the first of its kind to be shown to be effective in patients that have dry eyes. So they spend a brief bit of time. You want to start over?
No, I think it's set some ambiance. It's fine. It's fine. Let's
Sorry.
keep going. Yeah, no worries.
Yeah. So the more fundamental question that they're asking though is, well, how effective is Restasis? Is Restasis Restasis is supposed to work for dry eye, but is it effective or not? And they say that they go through a bunch of different things that suggest that the randomized controlled trials or the placebo trials did not show that Restasis was that effective in treating dry eye. There were FDA applications, multiple FDA applications, and then finally it was approved based on a surrogate endpoint, something called the Schirmer sign. And it's not approved by the European Union. It's not approved in Australia. And so, this is not even an efficacious drug. And yet Americans are paying through the nose for it to the tune of, they say, $2 billion. $2 billion, Medicare Part D, federal tax dollars also being spent to a massive amount as well. And, they end by saying, think about all this wasted money and what else it could have been used for, things like funding the Dartmouth Health Policy Institute forever. So that is the gist is, right. We're spending too much money on a drug that is not effective.
That does not work. Right.
Yes. So what do you think, Michelle?
Well,
have we been duped? Are physicians so easily duped that we're using this drug that does God knows what?
Yeah, I mean, if that's the case, if a pharmaceutical company can just have a marketing campaign to and make billions with a product that doesn't work, why do they invest in R&D? Why can't they just put some saline or something, put something completely inert off the shelf? I mean, why bother even do any research? It sounds fishy. And then when you dig through this, so I want to bring attention, because this we hear a lot: the drug doesn't work. So on what basis do they say that the drug doesn't work? There were two criteria that the FDA had asked the company to demonstrate efficacy on, and one of them is a criteria on a sign on the ocular surface damage. There's some kind of index of ocular surface damage, and to see, and apparently it failed to meet statistical significance. The other one is a symptom index score. Okay, but what's interesting is that in none of this does it ask the patients if they feel better using the drug than not using it, or using the artificial tears, right? There's nothing. I mean, if you look at a symptom score, it makes it sound like we're gauging the subjective, the symptoms of the patient. But what it is that, it's a score that says, and it's a scale for each symptom. More often than not, I have dry eyes in the morning. Yeah, so you answer yes most of the time, little of the time, that sort of thing. Or when there's air conditioning, my eyes feel dry. Some of the time, most of the, that kind of thing. So you get a composite score at baseline, and then you can get a composite score after the use of the drug. But I mean, for one thing, to me, that's very different than just saying, do you like being on the drug better than what you were on before?
Well, Michel, how can you trust the patients? I mean,
that's true. We can't.
Snake oil, and if they feel better with snake oil, then is that?
That's terrible.
Trusted to know what's good for them or not.
It's amazing. It made me think of it. I mean, imagine you were, you go and you see people drinking Coca-Cola instead of Pepsi, or vice versa. And you tell them, which one do you like best? They say, I like Coca-Cola better. And then you say, well, that sounds fishy. Let me give you a questionnaire to fill out. That's that's the kind of thing. I mean, why not ask the patients, do you feel better or not? I mean, it's not that you need to ask. The FDA, of course, needs these kinds of indices to make it objective.
Yeah.
But why would patients continue to use something to the tune of billions of dollars because of a marketing campaign? I mean, I find that a little bit, fishy. That they would continue to use and pay, and especially nowadays when there's out-of-pocket cost and whatnot, that they would go and use something that doesn't work.
Yeah, you don't think they could be led by their physicians to say, "Hey, this is awesome and this is working really well." I mean, the physicians are in cahoots with the drug companies.
Correct, of course. And there's a statement in the paper about the role of physicians. Clinicians typically do not learn about new drugs from regulatory documents.
Right?
Many learn from company-sponsored promotional efforts, such as detailing visits and events where foods and beverages are provided. Okay. Right. And these statements, right? It's always.
We are the pimp. Yeah, we are pimps.
Correct. We're pimps for the drug companies. It's always vague. It's physicians typically, right? Typically do not learn. Typically, I'd like them to quantify this. Typically, what does that mean? Do they have a p-value to back that statement? Now, of course, I know that there are statements that show that physicians prescribe more, if they've been under certain circumstances. But as we talked about in a previous episode, all of this is very fishy. There may be. I mean, in the U.S., how many physicians are actually given gobs of money by Allergan for eye drops and whatnot? For and presumably ophthalmologists might be. But still, I mean, there's so many competing factors and whatnot, and
yeah.
I mean, so I can't imagine. Go ahead. You did some research.
I did some research.
Okay, good.
I called
because we don't want people to just take our word for it, right?
So I cold called an ophthalmologist. I said, what is this thing about restasis? I mean, I've barely heard of restasis. I was like, I don't know. And so what do you think is going on with restasis? He says, oh, do you have a problem with restasis? Do you know somebody? I was like, no. There's this controversy, and what do you think about the drug? He's like, well, in my practice, I don't know the data that tremendously, but in my practice that I've used it seemed to work wonders. There are patients that who are failing regular saline drops. These are usually patients that are failing regular saline drops, and they come and we try it. And there's definitely a group of folks that respond really well to it. He pointed out that, you need to use the drug consistently for 3 months. And a lot of times people that don't respond aren't using it consistently for 3 months. And they really have to be trained well in terms of how to use it, because it takes a long time before it works effectively. But his feeling was that this was actually a fairly effective drug. I then reached out to somebody on Twitter. I didn't ask him for permissions. I want to say his name, but he's an expert in dry eyes, and I asked him about this thing, and he said that this was an editorial written by two internists who don't really know much about what they're talking about, and he says that, they got most of the things in the article wrong. He says it's been an amazingly effective drug. The ophthalmologists in general ignored this article. The 2 billion number is totally wrong. Actually, it's 1.4 billion is what is reported in sales. They rounded up to 2 from 1.4, and then that 1.4 apparently is not even correct, because that's the list price, and doesn't include the rebates. So he thinks the number is probably closer to 700 or 800.
Right. Although at that point, who cares? Even if it's 10 billions.
Right.
This is amazing, because I knew nothing about that. What you're just saying, that's really absolutely amazing.
Yeah. And the fact that, and it's interesting, it just goes to show you how much. Literally the whole article is utterly misguided and gives you the wrong impression. So when you talk to some expert within the field, now it's possible that the experts have gotten some funding from a drug company. I don't know exactly how much or what they've gotten and stuff, but you have two separate unrelated ophthalmologists that say, it's a drug that works. It's worked really well, and it's ushered in a new era in terms of how we treat dry eyes, in terms of using cyclosporin. There are multiple other drugs that are coming on the market. Patents are being approved. By the way, they have reapplied to the European Medical Association. They've reapplied to these other places in order to get the FDA approval. And by the way, the surrogate endpoint, these guys poo-poo the surrogate endpoint, saying the only reason the FDA approved it was the surrogate endpoint, which is something called the Schirmer's sign. I've never.
Right. It's a way to quantify the amount of
tears.
Of tears. You're right.
Yes. So what do I know? But he said, the Schirmer sign and the whole point is to get more tears, and the Schirmer sign quantifies more tears, and so we have more tears. So why is that a bad surrogate endpoint?
Right.
Do we want mortality benefit?
That's amazing. I really had no idea. I thought, when we started this episode, I thought that maybe, this was vaguely sort of ineffective and whatnot, but I figured something was fishy. What you're telling me here is really absolutely amazing.
Yeah. So it's actually an effective drug, and they don't have a single counterpoint. So, JAMA Internal Medicine is, it's essentially,
Oh, speaking of which, JAMA Internal Medicine, I tweeted about that. To get to this article, there's a barrage of pop-up advertising that you have to get to before you can even read the damn thing. A bunch of things that you have to click. Close. All these ads from pharma company.
Please tell me that one of the ads was for Allergan, for Restasis.
No, nothing. Well, no, I don't think it would have been funny, but it wasn't. No.
But no, this raises a larger question, right? Yes, I know we were going to talk about Restasis and the.
No, it is a larger question. This is, clearly it's ideological. This thing about, the pharmascolds, and they hate the term, but the term is extremely appropriate. That's really what it is. It's, this notion that anything that comes out of pharma has to be suspicious, has to be manipulative, has to be wrong.
Yeah.
But it's ridiculous on the face of it. You really don't need to even dig into as much as you did to figure out that there must be something fishy. Why would a patient continue to use month after month and prescribe and refill the prescription for something that doesn't work?
Right.
I guess at some point it has.
Yeah. Well, I thought you were going to bring up the fact that it was, it's probably covered by third parties and,
Yeah. So that probably, it does play a role. Correct. It plays a role that, the bar is going to be less. But even then,
right.
You still, even if it's free, if it's free and you put the stuff in your eye, and if it doesn't work, you're going to throw it away. Right. Who wants to do that?
Who wants to do that? Yeah. Right.
For the fun of it.
Yeah. The remarkable thing is that in trying to point out how fake pharma is here, they have overreached and become even faker than
it is. It's
fake news. It's remarkable to me that I grew up in an age where JAMA was JAMA, right. All these great journals where that was the rock of evidence. This is facts. And here you have literally in the debate that's been taking place, they are fake news. I use that.
It's infantile. It's really an infantilization of the debate. I'm not saying we shouldn't I mean, there are points of criticism that one can raise against pharma. There's no question about it.
Right.
But not to say, oh, all you have to do is have a marketing campaign and then you can make billions of dollars a year.
Yes.
It's really
it is
idiotic. It is idiotic.
Yeah.
And yet you get retweets, you get, it's in the pages of JAMA and everywhere else, and everybody claps.
Right. And the interesting thing is that a lot of healthcare journalists are ideologically on the same fold, and they are dying to hear this stuff. They're dying to paint some folks as the bad guys, and they then retweet it and amplify it, and you have this giant bubble of just fake stuff.
They completely lose their objectivity on this. It's amazing.
So who should you believe, Michel?
Right. You should believe the Akkad and Coca reports.
Yes, exactly right.
People should subscribe to this. Every week we give you the truth.
Right.
No big news here.
Yes.
But yes, I mean, this is crazy. I'm going to tell you a little story. It's funny because there's a personal aspect to this. Not that I'm a dry eye, but in a way, I know more about dry eyes than I ever thought I would. When I was a fellow at UCSF, I was working with in a genetic lab on mice that had been genetically engineered to have a knockout of an enzyme that esterifies cholesterol. Mm-hmm. Because cholesterol esterification is what happens in macrophages in atherosclerotic plaques. You have foam cells that are full of cholesterol esters. And so, basic science for me was complete drudgery. I did it. I should have known better, but I had no patience for it and no real interest in it. But I did this. So for 2 years, I had to go into the lab and these mice. So the mice were genetic knockouts, and otherwise, if you look at them, they seemed indistinguishable. And the lab had the mice for 3 years. They had published a bunch of papers characterizing the phenotype of these knockout mice. And but after a while, I was using them, and I had, for the purposes of my experiment, I had to determine whether the mice that I was handling was a knockout mouse. The mouse that I was handling was a knockout, or was it a wild type, and so forth. And after a while, I realized that the mice, their eyes looked funny. They looked funny to me, and so I and it was clear that it was the knockout mice that had these funny-looking eyes. So I did a histological section of the eyes, and it turned out they had a depletion of the cholesterol esters in the meibomian glands, which are really the glands that produce the tears that are implicated in the dry eye syndrome.
Oh, interesting.
So then I presented that at a lab meeting, and the PI said, "Wow, this is very interesting. Let's do a little marketing research. What is the market for dry eyes? See if we can sort of." So I looked at the market, and it wasn't the focus of the lab. So I'm not saying that's why, but I did somebody looked at the market size, and it seemed really paltry. It was very little. So then I said, that's not interesting. That's not interesting. God. But the reason it was paltry is because there was nothing works. Right? It's not because it was paltry because nothing worked. So now works,
you could have been the next Zuckerberg.
Right. Well, I mean, right. I mean, that enzymes probably had nothing to, it wouldn't have led to a drug, but it goes to show you that this, just saying that you can make billions just on the face, just on the basis of a marketing campaign, that's really, it's silly, and it should stop. It should stop. I mean, if doctors are watching this, or residents or students or whatnot, I mean, really, I'd like to caution them, because we hear this so frequently, that all you need is marketing and advertising, and then it puts the doctors and the patients in a trance. You see the ad on TV, and then you're going to call your doctor and say, "I want this," and then you're going to use it and be hooked on it for the rest of your life. This is really silly. Have we? Yeah,
no, absolutely.
Anything else?
It's certainly a narrative that people like, but there's a little. The truth is far from what the narrative is. So.
It is.
All right, sir.
Nice chatting.
Yep.
See you next time. Bye.
Yep. Bye-bye.